Hi, thank you for joining us today. I'm Dr. Jennifer Griffin, and I will be joined by Dr. Mary Sherlock. We are two Canadian pediatric gastroenterologists, and today we are talking about eosinophilic esophagitis, or EOE, understanding the basics. I have no disclosures to declare, and Dr. Sherlock has been an attendee on the advisory board for Sanofi Canada. Our objectives today are to define eosinophilic esophagitis and its impact on health, identify key risk factors associated with EOE, explain the process for making a diagnosis of EOE, and explore treatment options for EOE. So let's start with exploring what is eosinophilic esophagitis, or EOE. So EOE is characterized by both having clinical symptoms as well as pathologic tissue findings. So you need to have a pattern of symptoms suggesting esophageal dysfunction, as well as finding active inflammation within esophageal tissue, which are predominantly eosinophils, with at least 15 eosinophils per high power field when the pathologist is looking at it under a microscope, with the exclusion of other causes for this eosinophils within the esophageal tissue. The prevalence of EOE worldwide is about 1 per 2,000 people. In Canada, as of right now, we don't have a clear incidence and prevalence rate that is known. There is a prevalence within genders, and there's a male predominance with a male to female ratio of 3:1. The mean age diagnosis was between 6 to 10.5 years based on Canadian data. Patients might present in varied ways, and so that clinical presentation can also depend on the age of the patient. In younger children, you may have food aversion or food refusal, or children may appear to be picky eaters or be very behavioral around feeding and meal times. They can also present with vomiting, particularly around eating. And one classic symptom is dysphagia, where children may describe issues of food feeling like it's stuck in their esophagus when they're trying to swallow, or feeling like the food is stuck and can't go down, or that their esophagus is tight. Impaction is where the food is stuck and cannot pass down further. They can also present with reflux symptoms, which might include heartburn or regurgitation of stomach contents or food. And sometimes patients will describe specific foods, and it doesn't necessarily mean those are the triggers for the inflammation itself, but this may be specific textures of foods that are harder to pass when there is inflammation active within the esophagus. Looking at an algorithm for making the diagnosis for eosinophilic esophagitis. So when you have someone presenting with symptoms that are suggestive of EOE, our next step would be planning for upper endoscopy. On endoscopy, some of the signs that may make us consider or suspect EOE, as you can see in the first box, this is demonstrating linear furrowing, which are these linear creases that go longitudinal along the esophagus. In the middle picture, this is white exudate. That can also be a finding with EOE. And the last picture is showing you trachealization, which looks like tracheal rings, but within the esophagus. And these signs can indicate EOE, but do not make the diagnosis. How we make the diagnosis is on endoscopy, we take biopsies of the esophageal tissue. So we'll take biopsies from different levels of the esophagus, ideally lower esophagus, mid esophagus, and upper esophagus. And these biopsies are studied under a microscope. The criteria for making that diagnosis does require a number of eosinophils greater than 15 eosinophils per high power field. Some other findings that can be described by our pathologists include eosinophilic microabscesses, superficial layering, extracellular eosinophil granules as well. So if we have the classic symptoms or symptoms suggestive of EOE, perform an upper endoscopy and find greater than 15 eosinophils per high-powered field, and we've ruled out other causes of esophageal eosinophilia. We can then make the diagnosis of eosinophilic esophagitis. There are some risk factors that can put the diagnosis of EOE at a higher incidence or a higher risk. So these risk factors includes having a personal history of atopic disease, and this includes allergies, which can be seasonal allergies, food, medications, asthma or atopic dermatitis or eczema, a family history of atopic disease, a family history of eosinophilic esophagitis, and also that male predominance. So now I'm going to hand it over to my colleague, Dr. Mary Sherlock, and she's going to talk about treatment for eosinophilic esophagitis. Thank you so much.
Thank you very much, Dr. Griffin, for bringing us through the diagnosis as well as the symptoms and risk factors for eosinophilic esophagitis. My name is Mary Sherlock, and I'm a pediatric gastroenterologist. Over the next few minutes, I'm going to bring us through the treatment of eosinophilic esophagitis, and this will apply to both pediatric and adult patients. So firstly, why do we treat eosinophilic esophagitis? Well, we treat it for a number of reasons. Firstly, we want to make our patients feel better. We want to improve their symptoms and also improve their quality of life. We're aiming to optimize growth and development in children. And overall, for all patients, we are wanting to improve the inflammation that is in the esophagus in EOE. The reason for this, not only for improving symptoms, is that we are hoping to prevent long-term complication, in particular a stricture, which is a narrowing that can form in the esophagus. When we think about treatment, we do have a number of options. Broadly, we can categorize these into food elimination treatment and medical therapy. If a complication does occur, then this will be treated differently, and often this is a stricture which needs a dilation. For food elimination, we have different strategies which will involve eliminating a different number of foods from the diet. Medical therapy, we now have several different treatment options that may be used, including acid blocking medicines, sometimes known as proton pump inhibitors or PPIs, swallowed steroids, and more recently, a newer biologic medication. If a stricture occurs, then this is managed or may need to be managed with a dilation procedure. For this talk, I'm going to focus on the dietary and medication management of eosinophilic esophagitis. So what dietary options do we have? We actually have a few different dietary strategies that we may employ when we're treating eosinophilic esophagitis. Sometimes we will remove one food from the diet, and this is very often milk or dairy, as dairy is the most commonly recognized food trigger for many patients with EOE. More broader diets then involve removing larger numbers of foods from the diet, such as milk and wheat, in a 2-food elimination diet, or we can broaden this to eliminate 4 foods or even 6 foods. And this is based on the foods being known to be the most common triggers in patients for eosinophilic esophagitis. They may not be the triggers for all patients, but if we think about a large number of patients, these foods have been identified in studies as being the common trigger foods. Sometimes we will use a diet that is extremely restrictive. It's called an elemental diet. And this is where the nutrition is delivered in a fully broken down form. It's a liquid formulation. And for different reasons, it is very rarely used, but will sometimes be used in patients that have challenging eosinophilic esophagitis. We do know that allergy testing does not help us to identify the triggering foods, and this is why we approach dietary therapy empirically, using foods that we know are common triggers for many patients. Which diets are more effective? Well, in general, the more foods you eliminate, the more effective we will see the effect on the EOE. However, the more foods we eliminate, it becomes more difficult to stick to and to implement. Studies have shown that starting off by eliminating one food, in particular dairy, may be effective in about half of patients, which is a good response rate in terms of settling down the inflammation when they look at this under biopsies. Many patients will feel very well with just eliminating one food. If we look at 4-food elimination diets, we see again quite a good response in terms of the biopsies and also how patients are feeling. And again, as I've mentioned, eliminating more foods, more patients will have responded to this, both when we look at their biopsies and when we ask about their symptoms. The elemental diet, as I said, which is the fully broken down diet, is the most effective, but we very rarely prescribe this. It tends to be difficult to administer, and we often need tube feeding to do this, but it does have extremely high remission rates. When we do dietary therapy, we know you can look at the least foods that you eliminate will be easier to manage, but may be less effective. And as we increase the amount of foods that are eliminated, the effectiveness of the dietary elimination therapy increases. So a common strategy that we will employ is that we will first remove 1 or 2 foods, which are known to be common trigger foods from the diet. And these will often be, as I've said, dairy or dairy plus wheat. Then ideally you repeat the upper endoscopy to see how well the patient has responded. And we will look at the appearance of the esophagus, but take biopsies. If the scope findings are good, then we can reintroduce an previously eliminated food. However, if they're not good, then we may need to think about either broadening our restrictions or moving to an alternate therapy. Ideally, what we're doing is after we make a change is that we're reevaluating the esophagus with the endoscopy and taking biopsies, because we know that symptoms don't always correlate with what things look like under the microscope. So as you can see, we do often need several endoscopies to try and identify the triggering food. When we look at the literature to see, well, what foods are the most common triggers, we know that dairy is the biggest trigger for many patients. About 70% of patients, dairy is going to be their triggering food. Wheat is also another very common one, and this is followed by eggs, legumes, and then nuts and seafood. We do need to approach elimination diets with care. And the reason for this is that there really is a significant potential for calorie, nutrient, and vitamin and mineral deficiencies to occur when we are on elimination diets. So it's very important to have the involvement of a registered dietitian in caring for patients who are managing their eosinophilic esophagitis with an elimination diet. And this is important for doing pre-assessment nutritional risks, as well as providing guidance around the elimination diets and potential substitutes. In children, it's critical to monitor their growth and development. And we do know that elimination diets do have an effect on quality of life, and it can make the diet difficult to adhere to. We know in younger children, eliminating a lot of foods can lead to feeding aversion. So these are things that we need to pay attention to when we're managing EOE with elimination diets. An allergist will often be involved as well, because many of patients will already be eliminating other foods due to their anaphylactic allergies, and it can be difficult then to implement further elimination. So what about the medication options that we have for EOE? We can broadly categorize these into acid blockers or PPI, proton pump inhibitor therapy, or swallowed steroids, and more recently, biologic therapy. So the proton pump inhibitor therapy, this, if we look at our guidelines, is for many patients, if we're doing medical therapy, this should be considered first line. Swallowed topical steroids, we have a couple of different options, but these are basically asthma medications that we've adapted for use in eosinophilic esophagitis. So one of them is to make a steroid slurry, and the other one uses an asthma puffer. I'm going to talk about this in a little more detail in a few slides' time. We now also have a biologic medication, which is a type of antibody therapy, and this has more recently been licensed for use for management of eosinophilic esophagitis in both adults and children. And for children, they have to be over 1 year of age. So the acid blocker therapy, we know that these types of medications, they're very commonly used in the medical field, and they are very effective acid blockers. But the role in EOE is actually going beyond acid suppression. And we know from research that the acid blockers do interact with an inflammatory messenger protein, which are called cytokines. The other name for this is eotaxin E3. It has a role in bringing eosinophils into the tissue. So we know that acid blocker therapy can interact with this cytokine and ultimately reduce the eosinophilic esophagitis inflammation. So it is going beyond acid suppression, and we do tend to need higher doses than we would use typically for acid suppression. But for many patients, they will have quite a reasonable response rate. So it is a very reasonable first-line therapy to consider and to discuss with your doctor. What about swallowed topical steroids? So as I've said, these are the medications that we use already or are used already for treatment of asthma. So we broadly have these categorized into swallowed budesonide and swallowed fluticasone, and they are both different types of steroid therapy. The budesonide is actually an asthma nebule, or a nebule that would typically be used for asthma therapy. Patients will open the nebule and mix it with a substance, often sucralose or an artificial sweetener, to make it into a slurry or a paste. And then when they swallow it, it will coat the esophagus. There now is a tablet version of this that actually dissolves on the tongue. It is available and licensed for adult use, so patients over the age of 18. It is budesonide, so the same medication that we see in the nebule, and patients put this on the back of their tongue and swallow it. And then with swallowing it, it again coats the esophagus, and that's where it acts to improve the inflammation. Another way of doing the swallowed steroid is with fluticasone, which is like an asthma puffer. And in this case, the patient puffs the puffer into the mouth and swallows it, and then the medication coats the esophagus. Because these are steroid medications, it is important that patients, if they can, try to rinse out their mouth about 30 minutes after the dose. And this is to try and help prevent candida or thrush forming in the mouth. I do suggest to patients not to eat and drink for the first 30 minutes after the dose, and this is to allow the medication have time being in contact with the esophagus. Which one is more effective is a question I sometimes get asked. And there was a study that looked at this question. It looked at both the budesonide and the fluticasone for early treatment of eosinophilic esophagitis. And this was done in a trial setting of mostly adult patients. And it was this was the first trial that actually looked at both treatments, either doing swallowed budesonide or the swallowed fluticasone. And overall, both groups had a very good response, both in terms of their symptoms and what the biopsies looked like when the gastroenterologist went back and looked with an endoscopy. In the study, they found about between 12 and 16% of patients did develop some form of thrush in their mouth or within the esophagus. So that's why it is very important to rinse the mouth out about 30 minutes after the dose is given. And overall in the trial, it was felt that one treatment was not better than the other. Within the last couple of years, we now have a different therapy available to us, a different type of treatment. This medication is dupilumab. So this is the newest medication for eosinophilic esophagitis. And it's an antibody therapy, which is given about every 1 to 2 weeks, and it's given by injection. This works differently to the other medications, and it blocks proteins which are called interleukin 4 and interleukin 13. And basically, these are molecules that are drivers of inflammation and have been shown to be active in the eosinophilic esophagitis pathway. This medication has been used for several other allergic conditions, such as asthma, and eczema, as well as a severe form of allergic rhinitis that's associated with nasal polyps. So its use in eosinophilic esophagitis is now approved over the past 2 years. It's now licensed for adult patients as well as children over the age of 1. This study represents a very large trial of the medication in adult patients as well as teenagers over the age of 12 years. In this study, patients were treated either every 1 week or every 2 weeks with 300 milligrams of dupilumab. And then they assessed outcomes at about 6 months. They asked patients how they were feeling with different symptom scores, as well as checked their biopsies. And what they found was that in patients who received the medication either every week or every 2 weeks, their biopsies looked very good when they assessed them at 24 weeks after initiation of treatment. However, patients who were receiving it weekly tended to feel better. Medication was very well tolerated, and the most frequent adverse effect was some soreness around the injection site. So how do we know if the treatment is working? At present, the only way to know if the treatment is working is to reassess with endoscopy and biopsies. Less invasive testing is being explored, but it is not available to us to use clinically. So in terms of some takeaway points that I'd like you to remember from this talk is that eosinophilic esophagitis is predominantly a food allergy mediated condition, but there is also a role for environmental allergens. There are different treatment strategies, and dietary elimination may be very helpful and effective, but involvement of a dietitian is very, very important. We have a variety of medical therapy open to us, including acid blockers, as well as swallowed topical steroids, and more recently, the biologic antibody therapy, dupilumab. It's very important to have a multidisciplinary approach to care with involvement of the dietitian. An allergist is also extremely helpful to help manage the coexistent conditions, as Dr. Griffin's mentioned. Many of the patients have other allergic conditions as well as anaphylactic food allergies. No matter what treatment we choose, it's very important that we do want to balance quality of life, improving symptoms, and preventing complications when we make our decisions. Patient-centered care is very important when it comes to treating patients with eosinophilic esophagitis. There are many different treatment options, and it's very important to chat with your doctor to see what treatment will be most effective and work best for you.